Welcome to the New England Journal of Medicine at the annual meeting of the European Society of Cardiology. I'm Stephen Morrissey, Executive Managing Editor, and I'm talking with Deputy Editor Jane Leopold and Editor-in-Chief Eric Rubin. We're looking at the ABYSS trial, beta blocker interruption or continuation with prior myocardial infarction. Beta blockers have been part of the treatment of MI for a long time. So Jane, why do this study?
That's a great question. The benefits of beta blocker therapy for patients who've had a myocardial infarction comes from studies that were done really before the modern era of myocardial reperfusion strategies and the new pharmacotherapies that we have, such as our modern antiplatelet agents. There's also been a signal from some contemporary large nationwide registries that have suggested that there's an absence of benefit of long-term use of beta blockers. So it's time to reevaluate this question.
Eric, how did the investigators ask the study question?
Steve, it was an open-label, non-inferiority randomized controlled trial that randomized people with a prior MI, an ejection fraction of better than 40%, and no new cardiovascular events in the past 6 months, to either continuing or stopping beta blocker therapy. The primary outcome was a composite of death, MI, stroke, and cardiovascular-related hospitalization at the last follow-up time point, but that was at least a year after randomization. It was a very large study. They enrolled more than 3,600 people. At the last observation, almost 24% of those who had stopped therapy and about 21% of those who continued therapy reached the primary endpoint. This failed to meet their criteria for non-inferiority. Interestingly, they saw no difference in quality of life measures between the two groups.
Jane, are the results of this study applicable to patients you see in daily clinical practice?
Oh, absolutely. Beta blockers are prescribed to more than 90% of all patients who have had a myocardial infarction. And patients who have this are often taking many drugs. When patients come into the office, one of the first things they ask is whether or not they can stop a medication because they don't like taking pills. So beta blockers often come up as one of the pills they'd like to stop. And that's because they don't like the side effects of these drugs. Now that we have results from the ABYSS trial, we can say that, we have some data now to say that stopping the drug is not non-inferior, which is double negative, and it didn't improve quality of life. So this really does provide more information for the clinician seeing the patient in the office, and something that we can tell patients when the question of whether or not to stop the drug comes up.
Jane, beta blockers seem so 1980s. I mean, the studies on which their use is based come from an era when there weren't a lot of other drugs for use post-MI. So were you surprised by this result?
Not especially. It's, we have some earlier data from the REPLACE trial that talked about giving beta blockers to patients and whether or not we should be doing that. And now we have results from the ABYSS trial. And in fact, this is such an important question that there are several other ongoing clinical trials that are attempting to answer different versions of this question. Now, there will always be some subgroups of patients who will require beta blockers because they've had a complicated myocardial infarction or they have another reason for the beta blocker. But it doesn't mean that we should be continuing our blanket use of these drugs.
Thank you, Jane, and thank you, Eric. This study was just published at nejm.org.